Hello everybody, welcome back to another edition of ECG Insights. My name is Alex and I am back again with Dr. Kalgi. Thank you for coming back and joining us for another conversation about ECGs.
Thank you so much for having me, Alex.
All right. If you're not familiar with Dr. Kalgi, he is a consultant electrophysiologist here at Mayo Clinic for Heart Rhythm Services. He specializes in invasive procedures, specifically cardiac ablations for atrial and ventricular arrhythmias. His research focuses on cardioneural ablations, which includes electroporation, radioablation, and proton and photon beam therapy. And also his research has to do with better understanding mechanisms of arrhythmias and procedural innovations. And then he is also heavily involved with AI and the management of frequent PVCs. So welcome back and
thank you.
Thank you for joining us. And then once again, if you are interested in free ECG resources on Instagram, you can find them on Instagram and we'll put that in the description and whatnot. So. All right.
Perfect.
So before we dive into a couple of our ECG case studies, once again, learning objectives have to do with key ECG features, including rate, rhythm, intervals, and waveforms, and then also applying your basic interpretation skills, sometimes getting into a little the advanced for the more intermediate and advanced learners, and then also our conduction abnormalities and explaining how that's relevant to allied health staff and their clinical significance. So let's dive right in.
Let's do it. So, as we mentioned in in our prior session, that I like to break down these ECGs and rhythm strips into what everyone should be able to digest, like someone reading this for the first time in their life, and then moving on to the intermediate and advanced readers. So the key rule is you want to know where the ECG leads are placed, and just by the activation of the QRS complexes, the P waves, you can make a sense of where they're coming from. And we'll just real quick maybe take a minute to draw out the lead. So in the heart, lead 1 goes from the right arm to the left. So that's lead 1. Lead 2 goes from the right arm to the leg. And lead 3 goes from the left to the leg. And then you have these augmented leads, AVR, AVL, and AVF that go to the right, left, and the foot respectively. And then you have the precordial leads, which start at the right fourth intercostal space and then go all the way to the apex where you find V6. With that background, we look at all of these ECGs and try to figure out, okay, where things are coming from and if they make sense with the clinical picture for the patient. So looking at this specific ECG, what we see here, so we have 4 leads available to us. We have V3, lead 2, V1, and lead 3. So we know that the P wave here is positive in lead 2 and is positive in lead 3. So already we know it's coming from high up and going down, likely a sinus atrial activity. So sinus node being located here between the SVC and the RA junction. And if we had other leads, if we had lead 1, it'll be positive in lead 1 as well. If we had AVR, the P wave will be negative in AVR because of the same concepts. So we have a sinus P wave. Then we have a QRS, which looks pretty narrow, looks like a normal activation of the QRS. Normal QRS would be mostly negative in V1, and as we go across the precordium, it'll be mostly positive. So V6 will be tall positive, and you get that transition somewhere between V3, V4. Just a quick look at this, looks normal. You can see V1 is mostly negative, and we have a V3 that looks a little taller than V1, so that makes sense. But as we go along, we see PQRS, PQRS, then any transition should catch your eye. So when you look at a strip and there's something that looks a little different, if you look at it bird's eye view, you should catch that right away. And I'm not looking at this yet, just the first strip. So what we see here is you have a P, QRS, another P, but there's nothing here. There's no QRS, and then you see a P again. So this is a drop beat or a beat of AV block, and the atria is getting activated, likely in the sinus node. For some reason, it's not making it down to the ventricle. It's our job to become detectives here and figure out why that's happening. So just diagnosing this a little better, so I'm just going to erase this. It's important to look at the P to P intervals leading up to this. They likely are the same, and you can put calipers there to measure that, but then the P to P interval is not changing. But what we see here is the PR interval of the return beat is a little longer than the PR interval of the beat preceding that. And if you go back to your definitions, in AV block, if all beats are conducted P to QRS, but they're just longer, that's first degree AV block. Okay, so long PR. and typically longer than 200, 210 milliseconds. Second, I mentioned third degree AV block is when none of the P waves are making it down to the ventricle. So your P's are doing their own thing, the QRSs are doing their own thing. So that's complete heart block. But in second degree, some of the P waves are conducted and the others are not. So this would fall under second degree AV block. Dividing those further, if you have a second degree AV block where the PR keeps prolonging beat to beat, and then there's a drop, and then there's a short PR in the return beat, that is what we call Wenckebach or Mobitz 1. Clearly, no one can understand my handwriting, but hopefully you can hear me okay. Second degree Mobitz type 2 is when the PR interval is long, but then with the drop beat and the return beat, the PR interval does not change. So this PR interval was the same as this one. That, we would call that Mobitz type 2. So it's not getting progressively longer. There's just a sudden drop and then it comes back. So in this case, looking at this, we'll call this Mobitz 1. And why is that differentiation important is Mobitz 1 generally happens at the level of the AV node of the heart. The heart diagram's gone, but somewhere at this level as opposed to the infranodal level. Mobitz 2 generally happens at a lower level. So the block's a little more concerning there. So that's the first strip. The second strip is very different, but anything else you want to talk about here? Or
No, I think that one of the big things you pointed out, so you have your misbeat here, the computer, this is an example of an inpatient telemetry strip. Computer did a good job of just saying it's a misbeat, and we need to dive a little bit deeper into what you were just describing. The PR is longer here. We have our drop, then we have a shorter PR, and so we have just an intermittent episode of Mobitz 1.
Exactly.
Yep.
And then the second one is a lot more concerning, right? When we see a lot of nothingness, that concerns us. And the first thing when you look at that is you want to see, okay, there's some artifact here, right? So is this artifact, is this real? And looks pretty real because if you look at the P waves here, you can march these out. They look pretty consistent. There's that block beat. And then if you march these out, that you can see some P waves there. So if you can march or something through an artifact, is likely not the reason why we don't have QRSs here. It's probably a true AV block episode. Diving a little bit deeper into artifact diagnosis, you can look at the leads and figure out where it's coming from. In this case, it's kind of everywhere, right? So V3, lead 2, V1, lead 3. So it could be some external source, electromagnetic interference. If you saw an artifact just on lead 1, lead 2, and AVR, you'll think of what's the common point between this, the right arm. So they have the right arm is shaking. So you can sound very smart and be like, hey, just fix their right arm, or were they doing something at that time just by looking at where the artifacts are. Coming back to the bigger, the more important condition here, we have sinus rhythm, and then we have a dropped beat here. So likely this is a P wave that doesn't conduct. The next P wave doesn't conduct with a shorter interval, it actually conducts with a longer, and maybe this QRS is slightly different as well. So let's erase this. So if you look at this QRS is different than that QRS. And if you look at lead V1, we'll get a little more nuance. So this is where the advanced readers maybe will get some of these points. If the beginners don't get it, don't worry. The third or the fourth time you come back to it, this will make sense. But just kind of listen to what I'm saying and then keep that in the back of your mind. V1 looks a little different. It's got this rabbit tail pattern, right? It's got that RS, R prime pattern. When we see that as not normal activation, because if you remember, I said V1 should be mostly negative like that. It's a little wider, it's a little different morphology. That's a right bundle branch block pattern. Yep. And typically, when we see a right bundle branch happen in a normal heart, it'll be a long shot, meaning there was a long normal R2R interval and then a PAC conducted quicker, and that caused a right bundle branch block. That is normal physiology. In the EP world, we call that phase 3 block or aberrancy, and that's normal. But if you see a bundle branch block that happens after a delay, so meaning the heart has ample time to recover, but for some reason the right bundle is still not active, that is not a good sign. So that tells you that there's some disease in the infrahissy and infranodal conduction system. So the right bundle is diseased, and this is what we call a phase 4 block. So when we see this, that already should raise alarm bells. But then to make it more obvious, the patient decided to go into complete heart block after that. Why is that happening? Because this activation, let's say it was a normal right bundle branch activation, it came back retrograde to the AV node. and concealed in the AV node. So it's not producing a beat in the atrium, but because the AV node is getting activated now, it's not available for the next few beats. So when we see something like this, where it's a different morphology QRS followed by a string of P waves not conducting, we call that paroxysmal AV block. And with the clue of a phase 4 block in the right bundle, meaning a longer delay causing a wider QRS, that is highly concerning, and this patient should be heading to the pacing lab pretty soon.
Absolutely. And that was kind of my next question. At what point, this patient does go into complete heart block. They have a longer pause. Luckily, we still have P waves, but when we look at the full disclosure of this was a pretty long pause. And so we have those miscellaneous drop beats where we're kind of having some intermittent episodes of Mobitz 1. Mm-hmm. Then we have our pause that starts here and ends here, and we still have only just a couple beats, so it almost just, that's a pretty long pause. Yeah. At what point would you just recommend that they get a device?
Yeah, so great question, and actually something that created a lot of confusion among clinicians as well, because the guidelines used to define these durations. So 3-second pause or more is concerning. 5-second pause or more in AFib is concerning, but the guidelines have gotten rid of that, and for good reason. Because just what we saw, the mechanism of the pause, or diving deeper into why that pause happened, is more important. So if we see a concerning pause here with AV block, with evidence of infrahisian block, then you will think of a pacemaker even if it's a 2-second pause, just because this is an unstable conduction system. Another scenario, you could have someone who's in their sleep on a monitor had a 15-second pause, but you can see P to P slowing with their AV block, and then you see junctional rhythm coming in. If the pause is happening, if the block is happening at 2 different levels in the heart, what are the chances that both levels, both sinus node and the AV node, decided to give up at the same time? They decide to strike. Right. That doesn't happen. So then you think of an external cause like a high vagal tone. So in a patient with sleep apnea, or many healthy athletes overnight will have these 10-second, 15-second pauses. And oftentimes you all are reading it and then rightly concerned, and then tell the MD who's on call, hey, this is what we are seeing in this patient. And we call the patient, wake them up, tell them to go to the ER. But really all of that was a vagal episode. So that's where looking at these P2P slowing versus just AV block with no slowing in the P2P, they're very different things. So a long pause in the setting of a vagal, like a high vagal tone, is not concerning, even if it's 10 seconds, 15 seconds, 20 seconds. A short pause with evidence of infrahisian block is very concerning.
Okay. All right, and then this was just kind of an episode where you also have some 2-to-1 conduction as well, and it goes right back into normal. So now kind of getting into our next gear. So this, for the audience, this is a lot of information, but really what I want to focus on here is that the patient, upon completion of this Holter monitor, we have a left bundle branch block, we have episodes of Mobitz 1 that progressed into 2-to-1 AV conduction and complete heart block, so very similar to almost what we just saw. We had frequent pauses, with the longest being 2.4 seconds. And we're also having some polymorphic VT. Patient did express having symptoms with a variety of these episodes. Yeah. And as we kind of get into some of the strips, whether you're talking Winkie-Bach, complete heart block, 2-to-1 conduction, so we're having a lot going on here. And then also from a ventricular ectopy standpoint, pointing out once again, polymorphic VT here. There's a lot going on this ECG, on these examples. Where do you even start?
Yeah, so let's go back to page 1 and just start with the report. And you're right, Alex, there's a lot of information here. Sometimes it can be overwhelming. The key things I focus on, so I look at the basic rhythm. So I'm going to see what they're doing for the most part. So they already have, they have some conduction disease because they have an underlying left bundle branch block. And then we see second degree Mobitz type 1. So this, if we just saw this, that won't be as concerning because, like I said, this is an AV node level of block. But this block in the left bundle is below the AV node. So that's infrahisian. So this patient has likely a multi-level block, just from the first line you can gather that. Then you can see, okay, what is their escape rhythm doing? So if they are having block, how fast are they going? So look at the average heart rate was 40. It's quite slow. Again, there are some elements here. We need to see how old the patient is. We need to see what their baseline vagal tone is. Are they an athlete? But let's say this is a 60-year-old patient that's still like very low and not athletic, the heart rate of 40 will not be normal. So even though the longest pause was 2.44 seconds, which doesn't sound very long, it's very concerning.
Right.
The other question is, when did that pause happen? So when we have patients getting that in the middle of the day when they're up and about and they're active, 2.4 seconds can be super long. So if you're on a bike and you have a 2.5 second pause, that's enough to cause you to pass out because your body needs high blood pressure at the time. If you're sleeping, you can have a 10-second pause and that's not as important. So the timing of that pause is important.
And so what's nice, kind of just going off of that point, is when you look at the overall time frame of when these pauses happened here in blue, they're all in the middle of the night.
All in the middle of the night. So if we just saw this without the left bundle, without some of the other signs to tell us they could have infranodal conduction disease, I won't be very concerned about this. But now knowing that they have left bundle and this, I want to see what that pause looked like because of that. Now the last point, since you mentioned this patient had polymorphic VT, that's very, very concerning because when we talk about people with bradyarrhythmias dying, passing out, most people think about them passing out because their heart rate's low and their blood pressure is low, and that makes sense intuitively. But that's not the main reason why they died. The main reason why patients with bradyarrhythmias, AV blocks, die is because they have this pause, they have a PVC after that, and they can have a run of polymorphic VT like a torsade. We discussed this in a previous session where you had frequent PVCs in a patient, but the PVCs make the next QT interval longer, and that's when they can go into these torsade rhythms. The same thing happens with the pause. If you have a long pause, the heart is sitting there waiting forever, long depolarization, the repolarization is following, that is going to be longer. So the QT will be longer. So if you have a PVC that falls in a bad time there, that can trigger torsade. And unfortunately, that's how these patients die. So when we see these, we want to minimize those pauses, get them a pacemaker sooner than later.
Absolutely. And then going through, and this was that multifocal.
Yeah. And we can see, so this is, we don't have all of the onset, but it'll be something like this, where you have a long interval and a short interval. So after this long interval, you can see the QT is not even done here. The T wave is about halfway done. That is the point I'm trying to make, is after a long RR interval, the QT is going to be longer. And if you have a PVC fall there, in this case, this patient was lucky. In this case, not so lucky.
Absolutely.
And then you had one with the 2-to-1 AV block as well, right? Is that?
Yep, right down here.
So perfect. So this is an important tracing too. So when we see 2-to-1 AV block, I'll spend a minute talking about this. You cannot put them in a bucket of Mobitz 1 or Mobitz 2 because you just don't have a long enough segment of normal conducted beats to tell the difference. Because how do we tell the difference? We see progressive PR prolongation, we see a PR interval coming back that's shorter. But if you don't have like 3 or 4 beats where you see that happening, then it's hard to tell. So we just put that in its own bracket. It's just 2-to-1 AV block. But there are other clues. So if you have 2-to-1 AV block in a patient with a wide QRS, like in this case, it's slightly atypical if this is the same patient because lead 1 should be tall, monomorphic. It was left bundle branch block. But let's say there's some conduction disease in the ventricle and the QRS is wide, the 2-to-1 AV block is more likely infranodal. So more likely Mobitz 2 than Mobitz 1. But if you have a 2-to-1 with a normal QRS, a longer PR interval, and that is counterintuitive because if we have this versus, I'll be more concerned about this one because the QRS is wide and the PR is normal. So why is a normal PR worse than the long PR? Is because when the AV node gets blocked, the PR interval can stretch a lot more. The time from the atrium to the AV node can stretch a lot more, like 100, 200 milliseconds. The time from the His bundle to the ventricle does not need to stretch a lot before patient needs or is defined as having infrahisian disease. So it could be something as short as 20, 30 milliseconds. If you see a wide QRS, a normal PR interval in a 2-to-1 AV block like this one, that's a little more concerning than something like this. So even within 2-to-1, you had different flavors for the advanced readers out there. This one I'll put in the most severe category, or Mobitz 2 likely.
Absolutely. And the whole 2-to-1 conversation is extremely interesting because, I think even going back, so just because it goes into 2 to 1, and like in textbook world, most 2 to 1, like just like when people just learning 2 to 1 conduction, they automatically classify it as Mobitz 2.
Yeah.
But really, there's more information that you need to look into in those 2 to 1 scenarios, because maybe the 2 to 1 has to do more with Winky-Bach than it does Mobitz 2.
Exactly. But the way this was defined here, like if it's not clear, calling it 2 to 1 is just fine. And sometimes we pretend to be in EP, pretend to be smarter than we are. Sometimes we don't know, and then until we put catheters in the heart and see what's going on. So I think calling it 2 to 1 is just fine. But if you do notice a wide QRS, like here it was mentioned, left bundle branch block patient has a wide QRS, or other higher grades of AV block where you see more than 2 PVs not being conducted, that's important to throw in the main body of the report.
Absolutely. All right. So that concludes our session today with ECG Insights. Have a great day, everybody.